Okay, good morning, everybody. Hope you had a good evening. For those that want to go to dinner on Saturday, we've had 25 people signed up already. It's probably going to grow, so we're too big for the restaurant that we picked, so we're going to have to try and pick another restaurant that's big enough for all of us. And then it's been recommended that the club to go to after is called Plan B. So we'll go to Plan B after that. Yeah, and it's small apparently. Yeah, bad habits and then Plan B. I don't know, seems appropriate. Yeah. All right, so first talk of the day, very important one. We got a really good day today, seven speakers, or 7 presentations, 8 speakers. And we're starting off with Jamie Mack. Jamie McAlpin holds a Bachelor of Science in Nursing from East Carolina University in 2000. Her specialities include coronary care unit, cardiovascular intensive care, cardiothoracic open heart intensive care, Code Blue team, interventional cardiology lab, adult and pediatric, and electrophysiology lab, both for adults and children. In 2014, she began working with Iboga and researching safety and best practices. She also began volunteering with GITA, the Global Ibogaine Therapy Alliance, to co-author the clinical guidelines for Ibogaine or Ibogaine-assisted detoxification, which led her to deepen her research into the medical considerations and risks related to Iboga and Ibogaine. In 2015, she completed training to become an American Heart Association, BLS, and ACLS certified instructor, and continued working with GITA to develop the first ACLS for Ibogaine and Heart Saver CPR and AED training courses offered at the 2016 GITA conference in Tepoztlán, Mexico. She also presented on Ibogaine therapy, ethics, and safety panel discussion at the conference. Jamie is co-founder of IbogaSafe, an organization dedicated to on-site training and education to reduce harm and increase safety in Ibogaine treatment. Jamie.
Oh, thank you. This is a similar presentation that I made in Vienna. It's based on a poster presentation that my partner and I, Christine, did for the MAP Psychedelic Science Conference in April 2017. And poster presentations is like, they're just kind of set up at the conference for a couple of days and people look at them and so we wanted to make something that was more a harm reduction tool for providers. You can go to the next slide. So this is what the poster ended up looking like. You won't be able to read this, but I'm breaking it down in this talk. And we got a really good response at the conference from it. Lots of people asking questions, lots of education being done. So I think it was a success. So next slide, please. So the basis premise, we had to kind of mock the scientific poster presentation, but we're nurses, so this isn't going to be a very scientific talk. It's going to be more than a critical care nurse's perspective on adverse events and how to prevent them. So this presentation, a lot of this was talks that Christine and I had about people that she's treated, events that I had dealt with, a little bit of background on me. I've been a cardiac nurse my entire career for 18 years, and I just like the action. I've always gravitated towards hearts because it's a really good way to avoid boredom in your job. Heart patients pretty much always keep you on your toes. And so I'm fairly new to the Ibogaine community. I didn't start working with Ibogaine until about 4 years ago. And when I started working, it was one of the first major projects I did was to help out with the writing of the clinical guidelines. So you can go to the next one. So this would be just a brief review aspects of a safe Ibogaine treatment. These are the things we think are most important. So you have meticulous patient screening and selection. Some patients are not going to be appropriate for Ibogaine, period. And you have to be able to discern, who to say no to. This is not appropriate for you. Some patients are only going to be appropriate for low dose protocols. Some people are never going to be appropriate for flood dosing. So this is where screening comes in very handy and necessary. Patient preparation, they have to be prepared not just physically but psychologically and emotionally. This is a marathon process that they're going to go through, and I don't think anyone in their right mind would run a marathon without doing some training first. So they have to be, I think pre-care is very important. I know there's some people that are going to be talking about pre-care possibly later today or tomorrow. And then emergency response planning. This is the part that I kind of understand the best because being a cardiac ICU nurse and a cardiac cath lab nurse, I would be the nurse that would be handling these kind of emergencies when they go into the hospital and taking care of these patients when they come into the ICUs and things like that. Cardiac monitoring, I think, is the gold standard. I think people should be continuously monitored. Sometimes the heart gives some warning signs before big problems happen, and if you don't have your eyes on a monitor, you're going to miss that. And you can't really see in a dark room with a person laying unmonitored. You can't really see changes before they get drastic. And then medical staff with ACLS experience is very important. In addition to that, even just having all of your staff CPR certified. In my dream clinic, I would like to see everyone that I hired in that clinic to be CPR certified, down to the cook, the person that changes the linens, anyone that's going to see that patient or possibly discover that patient in the event of an emergency. And then aftercare, I know we have some great people talking about aftercare as well. How are they going to recover from this experience, not just emotionally but physically? You have to replenish electrolytes after the fact and things of that nature, and then how are they going to integrate this experience into their real life? That's part of the challenge when you're working with plant medicines, is you get these great, fantastic insights, but a lot of people don't have the tools to know how to apply that to their practical everyday life. But other people will talk about that. So next slide. The methods that we used for this was, I basically did a literature review. I reviewed 34 case studies of adverse events and deaths pulled from medical literature, Ibogaine related. And then the rest would be, some research we did for the guidelines, and then our collective nursing experience. My first 3 years as a coronary care unit nurse, I cross-trained with open heart, and then I did I trained to be a member of the resuscitation team for my hospital. So when someone called a code blue overhead at the hospital, I was one of the nurses that had to drop everything and run and handle that with a team of people. A code blue is when someone stops breathing, or when someone's heart stops, and they have to call in the emergency team to handle that. And it usually consists of a doctor, an anesthesiologist. Well, in my hospital, it was an anesthesiologist ran the code. An ER doctor came. A CCU nurse, which was me, an ICU nurse, a respiratory therapist, a pharmacist, and then we always had a chaplain and a security person. So it's actually a big team that shows up to handle emergencies when it comes into the hospital, because we have to handle all sorts of aspects of that. Next slide, please. So this would be myth number 1. And Christine and I actually brainstormed probably about 20 myths, but we went with the top 4 based on things we've heard the most and things that we believed were kind of the most damaging overall to to having adverse events. So, myth number one, Ibogaine is safe for treating all dependencies. Um, Detox and withdrawal is complicated. The more complicated ones that we have dealt with, and you'll see when we get to the numbers later, is polysubstance abuse. And that is an issue that's a lot more common these days than it used to be. So it's becoming, it can make the withdrawal process very, very unpredictable. Um, I worked at my first Ibogaine clinic that I worked at was more psychospiritual, so I don't have a lot of Ibogaine detox direct experience, but I have a ton of ICU level detox direct experience, which are the most complicated kind. It's usually someone had seizures or brain bleed or some kind of other incident that made their detox more complicated, and we have to put them into a medical coma and basically detox them while they're on life support in a coma, heavily sedated, and it's a very tricky process. It can be very unpredictable, and some of the most unpredictable ones I had in that setting would have been your alcoholics. Delirium tremens is a very life-threatening condition, and your speedballers, people that did uppers and downers. Those were always very tricky from a heart standpoint because the heart doesn't know whether to speed up or whether to slow down because it's got two drugs telling it to do two different things. And then when you're withdrawing off of those two drugs, same thing happens. The heart doesn't know what to do. So second point, obviously, is Ibogaine won't prevent seizures. So that's what makes alcohol and benzodiazepine detox tricky because the most dangerous withdrawal symptom from both of those substances is seizures, lowering the seizure threshold and putting people at increased risk for seizures. And then, of course, we have the QT prolongation issue on top of all this. And we'll talk a lot more about that during some of the case studies. Next slide, sorry. Wait, back one slide, I think, yeah. So the QT interval, everyone mentions, it is, you can see on the bottom of this diagram, it starts at the beginning of the QRS complex, and then it ends at the when the T wave comes back down to the what's called the isoelectric line. I like to, when I teach about QT intervals, I like to use the analogies of flushing a toilet. So this QRX complex would be you flushing the toilet, the heart flushing the toilet electrically. The toilet can't flush again until the water is refilled in the tank to be set up for the next flush. If you try to flush that toilet, it's not going to work. So the T wave is basically that QT interval is the whole period it takes for your heart to recharge electrically to be ready for the next QRS complex, for the next heartbeat. It's a very vulnerable period in the heart, and if anything out of the ordinary is happening electrically during that period, it can immediately put a person into a lethal cardiac arrhythmia. And a lethal cardiac arrhythmia would be ventricular tachycardia, ventricular fibrillation, and the heart can't tolerate any of those kind of rhythms for very long. The heart really doesn't function on that particular pacemaker as well as it does on the first and second pacemaker. That's kind of the third and final stretch for the heart, and that's when the heart is pissed and tells you that, something has to be done very quickly. Next slide. So these are some numbers. Out of the 34 case studies, this is not, super scientific, but these are the numbers. Basically, I went through the 34 case studies to organize my thoughts, and I made a list. I made myself a color-coded list of all the contributing factors in each case, and then I would go through and count the different colors and see, well, how many times was this a factor in this particular case. So the numbers aren't really exact percentages. It's more just me counting was this a factor? Was that a factor? So polysubstance abuse was a factor in 17 out of 34 cases, and benzos in 8 out of 34 cases. Alcohol is a factor in 10 of them. Crack cocaine, methamphetamines in 11, and methadone in 8 of the cases. These were the biggest offenders substance-wise across the board. We'll talk about some other numbers later in the presentation. So next one, this case study I'm using just to illustrate how I do the counting because it's not exact science. This was a 27-year-old male found dead approximately 12 hours after ingestion. He was being treated at a clinic. Where did it say? Yeah, this was in France. In 2006, this occurred in France. It was published in 2013. Not a clinic? Okay. Okay, yeah. This was, yeah, I remember it was like a psychospiritual thing. Right. This was the direct result of this death, and one shortly before this was why Ibogaine became illegal in France. But this guy is, he scored the highest on my numbers that I just showed you because he was a polysubstance abuse. He counted for alcohol, crack cocaine, opiates, and methadone. So he clocked the most numbers on that mini, and benzos. Oh yeah, he had benzos too. 3 different benzos. I forgot about that. So he had no cardiac issues. His issue was mainly the benzos in his system. He was positive toxicology for methadone and benzos. Methadone is a QT prolonger as well. It's a hERG channel blocker, more of a sodium channel blocker. And benzos, we have the seizure issue as well. His final autopsy report was aspiration pneumonia, which most likely meant that he stopped breathing, threw up, and aspirated. Or he stopped breathing to the point that his secretions could have aspirated. And a lot of people, he wouldn't have come back from that. So, but the coroner's report called it Iboga poisoning, which is bad press for Ibogaine, obviously, and I'm sure this was part of the France making this illegal. France is one of 5 nations where it's illegal. Yeah. So, yes. Yes, that was based on what they were told the person took. I don't think at the time they could do any kind of toxicology to figure out exactly how much was in his system. A lot of these case studies are limited information. You don't have all of what you need information-wise. Yes. Yeah.
I don't remember correctly, but exactly, but it was measured in the blood, the percent, the
Okay.
concentration. It was sky above the one that should correlate 2 grams of powder, and it was also powder of 7.2% of ibogaine in the root, which is the highest ever seen. Yeah, yeah. So from one teaspoon, nobody died, and also in the abstract of the article, it is stated it's combined poisoning with
benzos
and methadone.
and methadone, yeah.
So you see in the article that things are not the same as in heteroanamnesis, which is obvious because of the participations. Nobody, they tried to say, oh, he just took 1 spoon, but they didn't predict what this can affect but it's in the article.
Okay, good. I have all the articles. All right, so next thing. this is just in general too. This doesn't have to do with the case. So, qualified medical supervision is highly recommended because this is a complex thing that we're doing detox. You know, like psychospiritual, I kind of got a false sense of security the first 6 months or so that I worked with this because we did psychospiritual and I was monitoring them, and these are pretty healthy people. You know, they're not coming to us with metabolic challenges that your detox population will be coming with. And, you know, we never really had to do a lot of interventions. We didn't have a lot of heart rates dropping and blood pressure dropping insanely low. And I did a lot of preparation even with the people who had low heart rates to prevent that kind of thing. But detox is a different ball game. You know, psychospiritual is kind of black and white. It's pretty easy to know if they're a candidate or not. But in detox, in Ibogaine detox or even ICU level detox, everything's gray. So there's a lot of clinical judgment that needs to come into play. And there's really no substitution for qualified medical supervision. And then I just put kind of my opinion of what qualified medical supervision is. You want an MD, registered nurse or paramedic level of education and training. These are the, at least in the United States, these are the levels you have to get to even be allowed to take an ACLS course. They need to be proficient in EKG monitoring. They need to be able to spot these very subtle changes in the EKG that can happen before your much bigger changes happen. That can help them to kind of get ahead of things and possibly do some interventions to prevent emergencies. They obviously need to keep their ACLS current. And previous experience and comfort level with patients requiring resuscitation is important. You know, I can tell you, 18 years into my career, I'm very comfortable with resuscitation. But the first resuscitation I ever, you know, was in the room for, I was like a deer in headlights, just in the corner watching the show. And that's pretty much how I was reminded of that. I just completed a clinical rotation in North Carolina to get my nursing license back active there. It's active in California, but I need to be in North Carolina, so they're making me jump through hoops. And the last weekend I was there, I was with the charge nurse, and I was doing tasking. We were kind of free-floating, helping all the other nurses out, and we had a new graduate who was less than 2 weeks off of orientation on a medical cardiac floor. You know, very green, very inexperienced, but very good and wants to learn and asks a lot of questions. And I helped her admit a patient the night before, a heart failure patient, COPD, a bunch of issues. And then the next morning, myself and the charge nurse, she got busy with another patient. Myself and the charge nurse were taking vital signs on all of her other patients. And the charge nurse went into this guy's room and didn't know him, and he was agonally breathing. He was about to crash. So the charge nurse came and got me. I took one look at him, and I had seen him the night before. I knew what he looked like, and I said, you know, we need to call the rapid response team in. They call them rapid response teams now instead of code blue teams. But I said, we need to call the team in. This guy's only got one lung. He's going to crash really fast when he does. And within 5 minutes of getting the team there, he had stopped breathing. His heart rate had gone to the 40s. And our poor nurse, you know, new nurse whose patient it was, walks into the room because she hears us call overhead on the system. And she's just standing there with a look of shock on her face, you know, terrified, has no clue what to do, and freezes up. I can pretty much tell you everyone freezes during their first code, even if they've trained for it, even if they've done ACLS. This is something you have to get used to doing. And so it's good to have people who have done resuscitation before bringing them into Ibogaine resuscitation, because it's a little different than regular. But, you know, this nurse will get better. That's the thing. She'll be around it more and more and more, and she'll get a comfort level with it and gain confidence with it. and that's what has to happen. And then obviously you want people to have knowledge of Ibogaine pharmacology and risk and all the potential adverse events and how to deal with those specific to Ibogaine. Next slide. Slide 10. Sorry, I've got speaking notes and slides. Okay, so myth number 2, buying Ibogaine online and self-administering with a sitter is safe. This is a really dangerous myth that has caused a lot of the more recent adverse events in medical literature. More and more people are hearing about Ibogaine and it's a cure and it's this fantastic thing, but a lot of people can't afford to go to a clinic, or they can't legally travel and leave their country, or they have other issues, so they get talked into buying product online and giving to themselves at home with the sitter. Some of these cases were with no sitter. So 10 out of, and it's becoming a significant issue with Ibogaine. 10 out of the 34 cases I reviewed involved self-administration. So these were people who were most likely buying it online or from a questionable source and doing it at home, and it's a very reckless thing to do. The other problem is the online retailers give inadequate instructions. A lot of people say, oh, just go get an EKG, go get your liver tested with your regular doctor, who you're not telling that doctor why you are getting your liver tested or your EKG reviewed or anything like that, and you'll be safe. Just take this dose and you'll be safe. And that's just not true in reality. 6 out of the 34 cases actually said in the literature that they purchased it on the internet. And then the other issue is online retailers have sold counterfeit or contaminated properties. One of our case studies is actually a death that was not Ibogaine. It was counterfeit Ibogaine, basically, or Iboga. It was Iboga root. Next slide. Okay, so here's a couple of case studies of self-administration gone wrong. This was a 40-year-old male, 2 grams of Ibogaine and 4 grams of an uncharacterized booster purchased on the internet for attempted heroin detox. He did have negative toxicology, so there was no drug interactions with that. He took it at home alone, was found 8 hours later, unresponsive, covered in emesis, which means he vomited or something, and he was in asystole, which is the most terminal rhythm. So he was probably, his heart had not been beating normally for quite some time before he was found. ROSC is return of spontaneous circulation. So the paramedics were able to resuscitate him on the way back to the hospital. In the hospital, his QTC peaked as high as 588 milliseconds. Generally anything over 500, and we're worried about cardiac arrest. His life support was withdrawn after diagnosis of anoxic brain death. Anoxic brain death is the most common reason that we have to withdraw care after resuscitation, because the brain and the heart are the 2 organs in the body most dependent on oxygen. So when the heart stops supplying the oxygen, or the lungs, when either one stops supplying the oxygen, it's the brain that we start to worry about. And, good CPR can buy you time. But this guy was an unwitnessed cardiac arrest. No one was around him to even see that he had stopped breathing or that his heart had stopped beating. So this was a 2016 case. He had last used heroin 4 days before his hospital admission. He was definite signs of metabolic acidosis. He had low blood pressure, and they were able to get the body back, but the brain was not salvageable. No, it's on the right one. No, this is the 40-year-old male. So The ideal resuscitation, the ideal patient, the ideal Ibogaine treatment involves always watching this patient, because the ideal resuscitation starts within the first 3 minutes of cardiac or respiratory arrest. I teach ACLS as well, so we know a lot of the resuscitation stats. And basically, what we teach in that course is within your goal, the single biggest predictor for survival of cardiac arrest is from the time the heart stops until the time of defibrillation. Your goal there is to have that done to have electricity into that heart in less than 3 minutes. For each minute after that 3-minute mark, your survival rates are going down by 5%. So, and survival rates for cardiac arrest are not that high to begin with. The national average in the United States for out-of-hospital cardiac arrest is about 6 to 8% survival. But that's because no one sees a lot of them. A lot of these people get found after the fact. Certain places do really well in surviving cardiac arrest. And one of the studies I talk about a lot in my ACLS course is they did a really cool study in 2011, I think, in Las Vegas casinos. The actual highest survival rate for cardiac arrest in the nation, and possibly in the world even, is in Las Vegas casinos. Does anyone know why that might be? Defibs everywhere. There's a couple other reasons. Cameras everywhere. So nobody collapses. The only place that there's not a camera is your hotel room. If you're in the hall, if you're in the bathroom, if you're on the casino floor and you collapse, somebody's watching that. They're dispatching security. All the security is CPR trained. Every single person that works in a Las Vegas casino is CPR trained, just like hospitals, just like airports. Hospitals and airports also have good survival rates for that reason. But the biggest thing is just rapid access to CPR and defibrillators, and the fact that someone's always going to see you unless you have your cardiac arrest in your hotel room. That's about the only time people don't survive in Las Vegas. So eyes on the patient is very important, and eyes on the monitor during the time period that they need to be monitored is extremely important, because if the heart stops first, the breathing will become irregular, but there's going to be a time delay there. So you're already killing minutes and wasting minutes. And when we're dealing with hearts, we deal with everything in seconds, basically. I've had cardiologists tell me during cases when they think I'm being too slow with something, you're wasting milliseconds. And that's how important it is in a cardiac emergency to react very quickly and to know what to do and get the electricity in them. So it's a big red flag if you're a prospective patient going to a clinic. If they don't even have a defibrillator, run away. Like, don't allow them to give you Ibogaine, basically. Because, there are people out there doing this without electricity. And, if you've got to wait 15 minutes for something like that to show up, you're kind of guaranteed to have some brain damage unless that person doing CPR on you is really pro at it. Next slide, please. So this was another patient, 39-year-old. I gotta change my slide. 39-year-old got 7 grams of Ibogaine, and if that's correct, that's just an insane example of bad dosing advice. And he had no significant medical history or no negative toxicology on his autopsy. He had seizures 5 hours after ingestion. This guy also had a history of similar seizures 4 months prior when he first tried to use Ibogaine. So, this is also ill-informed. He didn't seek, provider supervision. Not that a provider would have taken him possibly after having seizures. And he did survive, actually. Whoever was watching him got him to the hospital in time to be treated. By the time he got to the hospital, while he was being monitored in the hospital, he had 8 more episodes of pause-dependent torsades. Torsades is the most common rhythm that on the patients that make it to the hospital to be monitored during their Ibogaine emergencies. This is the most common rhythm you see. This is the most common rhythm associated with drug-induced QT prolongation. It requires transvenous pacing in an ICU. These patients always require ICU level care because the transvenous pacer is usually inserted through central venous line or through the groin into the heart. It's actually a pacing thing that goes directly into the right ventricle of the heart and speeds up the heart rate. He was obviously having very slow bradycardia and then long pauses, and his heart was trying to compensate for the long pauses by activating the third pacemaker, the ventricular pacemaker, which is the one that we never really want to activate. His QT intervals were pretty insane. On admission, he was at 640 milliseconds. He peaked on day 2 at 730 milliseconds. He obviously couldn't be discharged until day 7 when he came down to a normal 400 milliseconds. 750 milliseconds is this particular study was published in 2015, and it did publish some of the EKGs, and it published the one with 750 milliseconds, and it's just insane looking. You're prolonging that vulnerable period where you're gonna start having issues. I've worked with a lot of antiarrhythmics, and back in the early 2000s, we had a new drug called dofetilide, a drug for atrial fibrillation to do chemical cardioversions. And back then, it was a new drug on the market. It was a very potent QT prolonger. So we actually, to start a patient on this drug, you had to bring them into the ICU for 3 days. You had to put them on an IV drip of this drug and titrate it according to your doctor, who was an electrophysiologist who went and did training with the drug company to be able to legally prescribe the drug. And we had to do EKGs, 12 leads on them every 8 hours to monitor the QT intervals and changes. We had to do a lot of things. It's very heavily regulated when it first hit the market. Now you only have to go onto a cardiac floor. They don't do it IV. They do PO doses, and they do a daily EKG for a couple of days, and then they send you home on a dose. I have no doubts 100% if Ibogaine were to be, clinically trialed and legalized in the United States, it would have to go through the ICU level of care model first. It would be treated just like dofetilide when it first hit the market, where you would have to go into a hospital and have, ICU nurses and crash carts and all the equipment nearby to do temporary pacing at the bedside if need be, and all of these things. And I remember our first dofetilide challenges, and we would call our EP doctor and we'd be like, oh, the QT interval's at 570, and he would just say, okay, keep watching them and put the crash cart right outside their door. And so that was like our superstitious thing. We had to put the crash cart right outside the door just in case we needed to go in there and shock. And we did have to shock a few people a lot of times when they got closer to the 600 range. So I never saw 730 during the dofetilide trials, but so I have no, just because of this one case, if anyone regulating this read this case, they would make it an ICU model treatment thing, at least until they got more confident about dosing and that kind of thing. Next slide, please. Okay, and this is case study 3. This was the one, the 30-year-old heroin addiction, anorexia, methadone. She ingested some powder that she ordered online too. It was labeled top quality Tabernathia Iboga. She had a polysubstance abuse history. Her toxicology was positive for benzo and cannabis by urine and 11 different drugs by hair analysis. And then they did some really cool toxicology analysis on. They had a sample that was found on the site. They analyzed that, and it was not ibogaine, but it was another plant from the same family as ibogaine. That was just a more common, less expensive shrub, but that particular shrub also has cardiotoxic effects that, especially with the hypotension and the bradycardia and the sedation effects, could easily mimic and some of the side effects of ibogaine as well. So this got written up in medical literature as an ibogaine death, even though it wasn't ibogaine. But this just kind of illustrates the dangers of ordering it online, not knowing your source, not knowing where it comes from. The only way to truly know your source is to get it from a GMP lab with analysis paperwork and that kind of thing, or to go to Africa and watch them take it off the tree. Otherwise, how do you know it's not being stepped on with some other contaminant that could be equally or more dangerous? And this person did pass away. They were found after they attempted this detox. I think she was in a caravan or something and attempted this. And that was a 2016. All of these were 2015, 2016 cases. So next slide. So basically, it's a big risk to order it online. It's a big risk to be with untrained, inexperienced providers or sitters, family members, that kind of thing. And you have to have due diligence because of the nature of this and researching a safe setting for ibogaine. Next slide, sorry. Okay, so myth number 3. There is no risk if you low dose or microdose. I've heard this myth quite frequently. I actually had I had a friend call me last summer before last, and he had genetic hypertension, and he had a bad reaction to he was going on blood pressure medicines for the first time ever, and he passed out, and he had a bad reaction because they put him on something that was too strong. And a rather shady provider recommended that he microdose for his genetic hypertension. And he started reading online about things. He's a smart guy, and he contacted me out of the blue, and he said, "Jamie, someone recommended that I microdose to treat my hypertension because I'm scared of these Western medicines." And he goes, "But I have a history of a cardiac arrhythmia, and I have this genetic hypertension." And he goes, "Well, I've read online that arrhythmias is a contraindication." And so I had to reply to him, obviously, yes, arrhythmias is a contraindication. It's probably the number one contraindication. And it's genetic. It's not gonna help your genetic hypertension. If this was hypertension related to anxiety or other things, yeah, it might help. But this is genetic. And the guy was walking around with really high numbers, like 190s over 100s and that kind of thing. And so I said, you need to go back to your cardiologist. You need to tell him what happened with the first pill. And you need to get on something not so strong, because he told me what pill they put him on. I said, well, that's the problem. And he went back to his cardiologist instead and got back on got on a better pill. He tried 2 other pills and got everything straightened out. That particular provider got mad at me because he lost business. and got very ill that I gave my feedback to a friend who contacted me. So that would be a person that Ibogaine's not appropriate for. He didn't have any other issues that were causing this hypertension. He was born with it. Prospective patients should be fully screened and prepared regardless of dosing protocols. I think the same screening should apply to a microdosing patient that applies to a flood dose patient. Doses as low as 300 milligrams, which we'll review next in the next case study, have been documented to be fatal in people with heart conditions and arrhythmia histories and things like that. So next case study, this is from the original Dr. Alper fatality study. This happened in 1990, I believe. Yes. Yeah, this happened in 1990. And this was a 44-year-old female, took 300 milligrams of Ibogaine for psychospiritual purposes and became unresponsive 4 hours later. Past medical history of hypertension and an abnormal EKG 3 months prior to death. She had inverted T waves on her EKG, which is generally not a good sign and should have been further investigated by a cardiologist. I was informed in Vienna by lovely Norma Lotsoff, who hasn't met. Yep, Norma. I was informed by Norma that when they were doing this particular patient, the medical practitioner was a psychiatrist who didn't really believe that 12-lead EKGs were even necessary for Ibogaine treatment. And that's why we don't trust a psychiatrist's opinion on EKGs. You don't, you really can only trust a cardiologist's opinion on EKGs because EKG reading is a fine art form. It's a very subtle art form. It takes a lot of experience and it takes a very well-trained eye to not miss things on EKGs. My favorite electrophysiologist that I used to do the Defetali trials with in our coronary care unit, we used to have a name that EKG board, and he was the guy that would feed all the funny-looking EKGs to us, and a lot of them was him cracking on the emergency room doctors and the things that they missed. So even a lot of other doctors will miss these kind of things. When they autopsied this lady, she had 3-vessel coronary artery disease. So she had major blockages in all 3 of the arteries that feed the heart. There's only 3 arteries that feed the heart. And she had had heart damage from a prior heart attack. Females are more likely to have silent heart attacks, meaning they can have a heart attack with minimal to no symptoms and not know about it until the second heart attack, which is slightly bigger. Even males can have silent heart attacks. If the blockage is very distal in the coronary artery, you can have a heart attack with very minimal symptoms. They could just be short of breath or have a tight chest for a day, and then the heart attack happens, a tiny bit of the muscle dies, and they go on living until the next bigger event possibly takes them out. So she had had a prior heart attack that affected her left ventricle, which is the most important chamber of the heart. That's the chamber that pumps the blood to the body. So this lady came into this treatment probably with a little undiagnosed heart failure that wasn't showing symptoms yet, and undiagnosed coronary artery disease. The tricky part about screening people for coronary artery disease is some people don't have symptoms of a blockage until it's 99 or 100% blocked. Some people can pass the stress test and then a month later have a massive heart attack with 100% blockage in their artery. Coronary artery disease is the #1 killer of men and women worldwide for decades now. And 80% of people don't find out that they're cardiac patients until their first major heart attack that takes them into a hospital, or first major cardiac event, arrhythmia, heart attack, whatever. The horrible percentage about that is that about 50% of people don't survive their first heart attack. They don't survive for a year past their first heart attack. So, it's in my business we're fighting some pretty steep numbers, challenges wise, because I'm back in cardio nursing, and but we've done a lot to try to improve those numbers, and we get new equipment and new technology every year to try to improve all of these survival rates. There's a lot that we can do now that we couldn't do, in the past. So next case study. Okay. Um, 35-year-old female, 500 milligrams of Ibogaine. This is another psychospiritual. This person had a history of a congenital heart defect. This would be another big person that I would never touch with any amount of Ibogaine because congenital heart defects are very complicated. I did pediatric cath lab for a year. My first year of cath lab nursing, I did pediatrics as well, electrophysiology, and we're basically working with congenital heart defects. The other issue with heart defects, congenital heart defects, is these kids used to not survive to adulthood, but because of technology, they are now surviving to adulthood. But a lot of them are having electrical issues. A lot of them end up requiring pacemakers. A lot of them end up requiring are having coronary artery disease at younger ages because of their heart issues. They have valve issues. They have a lot of issues. So I wouldn't, I wouldn't think this is an appropriate patient the minute I found out there was a congenital heart defect. They're very complicated. So I got to go faster. So this is just all the exclusion criteria. This is all spelled out in greater detail in the guidelines. I'm going to get to myth 4 so I can wrap this up. Next slide, please. So next slide, after psychotropic effects wear off, one is safe from adverse events. The first study, Canalper study, showed a range of 1.5 to 76 hours post-ingestion for these events happening. Several of the events, 5 of the events occurred way past the post-ingestion. So next slide. What we recommend is monitoring for a full 72 hours after ingestion. This one was 2.5 grams. This was a 25-year-old self-administered 2.5 grams of Ibogaine. And over the course of 3 hours, he took it slowly. Past medical history, heroin addiction, and supraventricular tachycardia, which is an abnormal arrhythmia that also would make him more prone to have other ventricular tachycardias. He developed respiratory issues and cardiac arrest and acute heart failure. And his mother was the supervising sitter. And this case really makes me sad because his mother was the one who had to deal with this emergency. And I'm sure she's probably got a lifetime of survivor's guilt and grief of losing her child while attempting to do this detox. No, he was, well, it didn't say his weight.
2.5 grams of Ibogaine.
Yeah, 6.25 milligrams.
He might have been big, but I don't know.
Yeah, really huge.
Yeah. So it wasn't, yeah. Let me find him. Slide 20. Yeah.
He'd be really.
It's not being a dot missing. It's probably
Yeah, it doesn't mention what his weight was, and but basically by the time he even got to the hospital, he was in a decorticate position, which is it's a very textbook sign of very severe anoxic brain damage. Basically, they like clench their arms up, kind of. Everything just clenches up, kind of like you would see an arm go after a stroke. The entire body does this weird thing. So he had severe brain damage. And they tried very aggressive care on him because it's very hard to give up on a 25-year-old post-resuscitation. They did aggressive care, so they probably did hypothermia therapy, all sorts of things. They could have even done balloon pump, and he died 2 days post-ingestion because his organs just started shutting down. There's a very common thing after cardiac arrest is cardiogenic shock. Basically, this is what I suspect happened in his case. He went into cardiogenic shock, and his body just started shutting down from that. Next slide. Almost done here. 40-year-old female, 14 milligrams per kilogram. She had gastric bypass surgery and lost 135 5 pounds in 8 months. So that makes you worry a little bit about metabolic stress, even leading into it. And Ibogaine is more metabolic stress on top of that. But the cause of her death, she also had a benzodependence, which was not disclosed to her providers. And I'm not sure from the literature whether the providers did drug testing or not, but the literature did say they were not aware that she was on benzos. And she tested positive for 3 different benzos, so that was obviously a factor. And her cause of death was a heart attack. She did have coronary artery disease on her autopsy. So we have the cardiac issue and we have the benzo issue that probably contributed to this one. None of these deaths are Ibogaine alone. It's always Ibogaine plus a cardiac issue plus a toxicology issue or something of that nature. Next slide. And we already talked about this, 3 days minimum of monitoring and eyes on the patient. Next slide. So these are some more totals that I deducted, numbers of contributing factors. This is next to the last slide. Out of the 34 cases, positive toxicology was an issue in 12. Pre-existing cardiopulmonary disease was an issue in 10 of them. 12 of them had no cardiac history on autopsy or any otherwise, but all 12 of the cases with no cardiac history were either notable for positive toxicology, self-administration, so poor supervision, or electrolyte abnormalities that happened to contribute to the case. 21 of the cases suggested that the causative way that they died was sudden cardiac death. On an autopsy report, it's always going to be termed as acute heart failure, and arrhythmias were obviously documented on a lot of this too. Liver disease was a factor in 5 of them. Psychospiritual, there were 3 of them were psychospiritual, but the 2 of the psychospiritual had pre-existing heart conditions. We reviewed those earlier and should have been excluded during the screening process. The 3rd psychospiritual death had normal EKG done prior to it, but had electrolyte imbalances on hospital admission. They had a low potassium, magnesium, and calcium. So that was probably the contributing factor on that one. I hear the psychospiritual only myth a lot. I hear a lot of people, oh, we only treat psychospiritual people, and so, we don't think we need medical supervision, that kind of thing. Well, my first question to that is always, well, are you drug testing everyone and doing a full search on all these psychospiritual people? Like, how do you know it's not a covert detox attempt? Because there should have been a 4th one. There was a 4th one I was going to add to psychospiritual because it actually was a covert detox attempt. It was a person who went for the psychospiritual treatment and didn't bother to tell their providers that they were really trying to detox off of something, which changes the game. And then we talked about 10 self-administration, 6 internet purchases. Okay. And then that's the conclusion. Detailed screening is required. Preventing fatalities is only going to be possible if we really tighten our standards of care and really prioritize the safety side of this. It has to be safety first. And that's it.
We can have a couple of, no problem, we can have a couple of quick questions and then we're going to go straight on to the next presentation. So, first question.
Metabolic status, intermediate, fast and slow metabolizers. Slow metabolizers can have as much as 3 times of higher bioavailability. And I think that measure of 6.25 milligrams per kilo was in fact 6.25 milligrams per liter in a blood.
Oh, it was.
Because of the rule of thumb is that after ingestion of 10 milligrams per kilogram of Ibogaine, you get approximately 1 milligram per liter in the blood. So if that guy with the 2.5 grams, maybe he was really low weighted, and or slow metabolizer, this could exactly bring him to 620, exactly, approximately to 625. So it's now there are screening tests for liver enzymes, cytochrome P450, and this should also be considered, if not mandatory.
Yes, and that's in the added into the guidelines, the genotyping for the cytochrome P450 enzyme, because a lot of people, there's a lot of variation in the way any of those drugs are metabolized, and I think that should be required on especially on off flood doses and things like that. That should definitely be a requirement. Yeah.
Hey, Jamie. That was
Hi.
awesome.
Thanks.
I love the name Ibogasafe, and seeing your presentation, it just reminds me of every time I'm on the Ibogaine universe or Facebook or whatever, and I read someone who's wants to self-administer, wants to self-sitter. And I just always keep thinking, like, safety first, safety first, safety first. But those of us who've been in the community for, like, I've been around for 10, 12, 14 years. Is there like a bumper sticker we could come up with? Like some really, like Ibogasafe is really cool, and I'm sure you put some thought into it. But do you have any other short bumper sticker statements you say when you see that kind of shit online? Like, don't sit by yourself, get tested, don't buy it online. And any suggestions?
I mean, in my opinion, it's like playing Russian roulette, doing self-administration. You know, I haven't come up with any catchy phrases that we can put on a bumper sticker yet, though.
I like Russian roulette.
We need to brainstorm on that.
Okay, thanks very much. Right, our next speaker is Dr. Frederico Baretto. Frederico has a medical degree and master's degree in psychiatry from the Faculty of Medicine at the University of Lisbon. Early on in his career, he worked as a GP and in various emergency rooms, and then moved on to alternative approaches to achieve well-being. Frederico's most recent work has focused on holistic approaches to well-being, physical, mental, emotional, and spiritual. He's done extensive research regarding the various healing modalities available today and has coached many clients into transforming themselves. Experienced in mindfulness-based approaches to self-knowledge, he focuses on the importance of discovering the roots of our issues in order to achieve complete liberation from our self-imposed limitations. Frederico is also ACLS certified. Frederico.
Hey. Hi, everyone. So I did my presentation. I thought about going in depth with, lots of medical jargon, but then I thought maybe this community is more pragmatic. So I thought about writing more about what I experienced, what I reflected. It was important, if you're a provider. So that's more or less how I created my presentation. And so first off, so I can understand this audience more, so from the people who are sitting here, who's the first time attendee on a Ibogaine forum or conference? Okay, fair enough. And who has never worked or never thought about working in an Ibogaine treatment? Okay. Wow, Dana, I'm really impressed. You never seen it, Dana. Okay. Okay, fair enough.
I really respect this shit.
Well.
And I'm not trained. So I'll raise money.
Well, I agree it's very, very hard, so being superstitious may be helping you to protect some lives, but you can go to the next slide. When they approached me to do the presentation, I thought, well, I'm a newcomer. I've known about Ibogaine since the beginning of this year. I met some plant teachers, plant healers the past couple of years because I was trying to expand my consciousness and understand myself and my place in the universe, creation. And I was really impressed because I've been trying to meditate, mindfulness practices for some years now. And plant teachers really feel like it's like a big boost in your spiritual exploration. And so I felt, wow, this is amazing. This can be, used to the bettering of mankind. And it's very hard to work on yourself sometimes, especially if you have lots of self-imposed or self-created limitations, like all those addictions. And I never struggled with substance addiction, but behavioral addictions and all sorts of maybe food addictions in a long, far forgotten past. And I understand how hard it can be. The body has its own compulsions, and I feel some people really need an external help. Even though yesterday we talked about, liberation can only be attained from within. It cannot be given. You have to take it. Somebody talked about it, and I agree with that. But we can help a great deal to so many people here. I feel that they have lost their awareness of their own inner power, their ability to transform their own lives, their own body, their own mind. And so, I don't feel it's our responsibility, but I feel we have this opportunity to extend our hands and help those people. So that's why I got interested in Ibogaine, because I know how risky it is. And some people would think, well, it's not worth it. Why risk your career, or why risk your nighttime? Just sleep soundly and ignore all this risky business. And although I understand that perspective, I feel the conventional medical system really lacks in addressing, alternatives to whatever's being offered right now, especially in addiction, but many other situations like psychiatric conditions. So I feel if we don't push, if we don't face our own inner demons as providers and as a community, how can we, expand Ibogaine and offer it to people who might need it, in a safe way, so we don't, distort, we don't add more negativity to the Ibogaine's image, And I think that as providers, the more we work on ourselves, the higher the likelihood that we might be able to offer Ibogaine more and more to those who need it, without the unnecessary risks, and adverse events that might arise. So that's kind of my goal now that I'm, working with Ibogaine. My goal is to every day try and find whatever we can do individually and as a community, a scientific community, providers community. What can we do to improve safety and improve efficacy, because I think that's very important. I think Ibogaine is already great, but we can make it much better. So that's it. So just some statistics. UN Office of Drug and Crime, this is the preliminary report for 2018. And yesterday we already spoke about the ongoing dangers of the opioid crisis and the most recent fentanyl situation that has happened on the past decade. It's really escalated. As you can see here, opiates, well, they differentiate between, I think opioids merely substances that act on opioid receptors, and opiates are the ones derived from natural sources like, opium, etc. So fentanyl, it's seen as a major issue nowadays, and we've seen the deaths, and I'll show some graphs posteriorly, but tramadol as well. And although tramadol might seem like for some people like it's less strict, for example, in Portugal than morphine sulfate, but tramadol obviously has issues, so shouldn't be used in close proximity with Ibogaine for QT issues and some others. So it's interesting to see how it's being abused, especially in the northern hemisphere, in the African continent, because for its easy availability, and that might pose a risk in the future in that area of the planet. And obviously benzodiazepines, they're really, we're struggling nowadays with even prescription drugs being trafficked and sold in the black market. and that's a big issue as well. So as providers, we should always remain attentive to the benzo problem we are facing. So from 99 to last year, we have a growth, really serious epidemics of synthetic opioids related deaths, overdoses, especially those are mostly related with fentanyl. And yeah, can go. Yeah, so even the current president, who is not very fond, by the public, but is warned about the opioid epidemic. I'm not really sure what the U.S. is doing right now to fight it. Okay. That's it. Okay. So I think they've even prescribed opioids have been on the rise. Okay, Suboxone. Yeah, that makes more sense. So I think even prescribed opioids, and that's a big issue, and obviously that's increases, unfortunately, but increases the potential number of clients that we might have, right? And more than clients, it's the potential number of people that might need the benefits of Ibogaine, if done safely, obviously. And I thought, and I wasn't aware of these statistics, I thought the population was more aware of the dangers of opioid use. And obviously it's not. It's an epidemic and it's growing, so there's a place, obviously, for Ibogaine at the moment. So the number of deaths involving opioids have been growing, but it's mainly due to the fentanyl increase, yeah. So as you can see here, the pain relievers, so the deaths have been quite stable with prescription opioids in this graphic. And I thought, for some articles I read, I thought the great rise in opioid overdose was due to prescription as well, not just fentanyl. But from this graphic, although it has increased, it's not really due to prescription opioids, at least the reported cases. But apparently, synthetic opioids, predominantly fentanyl, they really count for a great number of overdoses. So I think that's interesting to have in mind, because not all drug tests, urine drug tests, account for fentanyl. Maybe if you're providing, maybe you should have that in mind and try to get some urine tests or quantitative testing for fentanyl, because most street heroin might be laced with fentanyl. So I think that's something to have in mind. Yeah, and we can go in. This is heroin progressing, but not as steeply as fentanyl. Yeah, and this is a combination. Speedballing, like Jamie said. It's a big issue. I'll talk further in the presentation about it. But the autonomic, parasympathetic, and sympathetic stimulation simultaneously creates lots of autonomic dysregulations. And that might be, well, that's a studied case. There's an article about it. It's very interesting. You can find it online. But it's basically Ibogaine might contribute to the unbalance of an already dysregulated autonomic nervous system. Somebody who's speedballing obviously is messing up their autonomic nervous system, and the body gets confused. Should I raise my heart? Should I slow my heart? And Ibogaine might trigger that already established unbalance. So I think we should be paying attention, and I'll talk about it further. So I just want to credit this slide to, very special nurse that's in here, Jamie. Yeah, so I won't talk about this, but basically it was the study, basically Alpers 2012 study in Koenig's, I think 2015, and maybe some other, and a handful of other cases. But basically it shows the main reasons why there might have been these fatalities might have happened, and I'll talk about those reasons in the future. But basically, I think most of these could have been avoided. Most of these, with the proper screening and application and studying of the potential patient client, I think most all of them can be avoided, and that's what I'm going to talk about. How to do these things, and I'm open to suggestions. People like Roman or whatever else, Dana, who want to add stuff while I'm talking. I'll be grateful. Yeah, well, Dana organized the conference, so I guess my Indian descent compels me to respect the elders. So starting with the equipment, if you're setting up an Ibogaine treatment center, equipment is paramount, obviously, and uh, always, like Jamie said, electricity is a lifesaver. You might be, a novice and not be able to put a line in somebody's arm or hand, and it might take time. And if you're in a hurry and you're, just stressing out and freezing like a deer in headlights, it's easier to use electricity for sure, if you know how to use it and how to troubleshoot, especially a manual defibrillator, because automatic have their own perks, but then they are too slow sometimes, and you cannot adjust stuff like you could with a manual. And when time is short, if you know what to do, then a manual is much better, because you know exactly what to go for the joules. You don't have to wait for the automatic to measure the electrical activity and wait for all the steps. You can just straight up act. So I would say a manual, yes, and there are some options online. Obviously, new ones might be over 10K sometimes. And if you're not, into that range of investment, maybe some second-hand. Maybe this is not great advice, but there are some great items online. Hospital used defibs like 20 years old. They're still fine. If they're tested, you can test their electrical output. You can connect the defib pads. Instead of connecting the defib pads to the machine, you connect a tester, and it tests the electrical shock. So you can do all sorts of things, and there are better alternatives, even 1K defibs with external pacing. External pacing is very important, because sometimes atropine is not enough to get the rhythm how you want it, and there's not enough time between having the patient needing pacing and taking him to the hospital, so it might be too much time to wait. So external pacing with a benzo to help sedate the patient, because it's very painful, even though it's less joules than defibrillation, it's still some, it's like doing those HAB machines, from the 90s. Oh, do your HABs at home, don't work out, just put that machine and it shocks your muscles. This is kind of the same, a little bit more electrical activity. So it makes your heart contract, but also all of these muscles in this area. So if you don't give benzodiazepines, it's really, unnecessary suffering. Respiratory, well, I've seen some people struggle respiratorily. It might be their base, they might have COPD, or they might have, long-term drug smoking, so they worsen their lung capacity. But from what I've seen, you can either get a tank or a concentrator. Tanks are more like a short-term kind of investment, and you have to refill them in Portugal. You can't refill them on a normal medical oxygen company, because you need you need serious licenses and to apply, and if you're not a pulmonologist or an internal medicine doctor, then it's really hard. It might be viable, but it's really hard. And a concentrator, you can get them, they're not really that expensive, from 300 euros up. You can get a decent concentrated, and they can serve the same amount of oxygen like a tank, from 1 to 6 liters. It's fine, and they're portable, they're lightweight, they're not as problematic as having a tank that has an inflammable substance inside. So I think if you're really serious about setting up an Ibogaine center, then I think this is something you should invest on, obviously. Obviously, to go with that, the pulse oximeter, always check the O2 levels, because sometimes during the Ibogaine experience, sometimes the consciousness drops too much, and from what I've experienced with plant medicine, not just Ibogaine, but also ayahuasca, sometimes you're too deep in your experience, and at least for me, from my personal experience, you kind of forget to breathe, or you're not aware if you're breathing. It's kind of weird, but basically what I've seen from some people taking Ibogaine is if they're too deep into their experience, I can't understand what phase they're going through, but sometimes it's like a dark place. You're not really in the physical, you're not really aware of physical senses, and sometimes the breathing rate drops just because of that. It might not be just a physiological breathing problem, but it might be an experiential, loss of depression on your consciousness. So always pay attention to the O2, and the vigilance should be, the vigilance tightness should be proportional to the level of consciousness and the vital signs of the patient. So obviously regulators, ambu masks, if you need more serious ventilation. And then IV ports, well, if you can get, intravenous peripheral catheters, then that's great. They're more comfortable. You can put an IV access to someone who's doing already Ibogaine, and you predict, well, this is a complicated patient, he's a poly user, he has some comorbidities, even though he was accepted in the program and the risk factors and contraindications were okay with him, he was accepted, still he's a complicated person. Maybe setting up a peripheral catheter might be beneficial, because when the time arises, it's too much stress, you have to do other stuff, so it helps. Yeah, obviously, I put avoiding adverse events, I put the scale here because it's important. People should be, at least aware to the decigrams, or if not centigrams, of the amount of Ibogaine you're giving, at least that. Yeah, and blood pressure. Well, always check the vital signs and see how they are, and that's how, as an Ibogaine provider, I feel we should be seeing how the body is reacting to the Ibogaine load and how to deal with it. Yeah, so medication, I've spoken with several people here, most providers, Anwar, Jamie, Claire, and many Jeffs in this community. And people advised different stuff, and that's fine. These are the ones I thought were the most essential, and I haven't put all the medication that other people have recommended me, but some, and I'll explain why. So ACLS medication, I think you should have it all. These are just some of them, but there are others, obviously. But I think you should have it all, especially magnesium sulfate and atropine. Those are paramount. Obviously, antidotes to overdosing, naloxone, flumazenil. Toradol helps if you're having someone struggling really hard. With pain, Toradol really helps in Portugal. I haven't found it. Someone can say if there's available. I don't think there's Toradol available IV form. So morphine sulfate, obviously, for obvious reasons, to stabilize them before, and short-acting opiates. Ringers, Hartmann's, they're really helpful when the blood pressure is. Yeah, sure, Jamie. Yeah, sure, I know, only in hospital, but in Portugal even, I haven't seen it in Infarmed listed, and, I don't have a familiarity with it in hospital care. Obviously, IV medication can't be sold in pharmacies in Portugal, and injectables only intramusculars. I don't want to be talking off my ass here, but I think it's mostly like that, IV obviously is hospital use, so it's not that easy to get unless you have a registered clinic. So, serum stuff, benzos obviously, and diazepam at least diazepam orally and IV. Obviously, we need something like that. Naloxone, nasal, well, it might help, sure. Ativan, what's Ativan? Alprazolam or something? It's alprazolam? Oh, it's lorazepam. Well, it's fine if you prefer lorazepam. I'm just saying what I think it's essential. Sometimes IV lorazepam it's a better choice. So that was the question, right? IV lorazepam. Yeah, sure. Especially with seizure situations. But I don't know where you're setting up, or people might be setting up their institutions. If you're like in whatever, Abu Dhabi or something, not likely. Maybe diazepam it's easier to get. That's why I put it here. So electrolytes, I think they're important, obviously. Electrolytes, how I've seen patients deal with this. If you don't have a fast way to measure electrolyte levels where you're treating your patients, for example, blood gas arterial blood gas machine where you do arterial blood gas measurement of calcium and potassium and magnesium, then I really seriously recommend against giving IV potassium. It's really more dangerous than might be beneficial. So really avoid giving IV potassium unless you're sure they're hypokalemic. The rest are really beneficial. You know, IV magnesium is essential. And talking about oral electrolytes, well, there's several forms of magnesium oxide, magnesium chloride, yeah, and some magnesium chloride in salt form. It's really foul tasting. It's really horrible. So unless you're just, you know, putting honey in the solution and trying to, you know, change the flavor, I think chelated magnesium is a good solution. It's a good alternative, and it's better absorbed. So I think that's great. Oral hydration formulas, you know, for babies or even adults who have diarrhea in third world countries or whatever. Just they have potassium, sodium in really good proportions. So I think that's a great thing. And always remember, if they have good digestive absorption and good renal function, then it's almost, not always, but almost always okay to give oral potassium. So thiamine, B vitamin, you know, people, if you're receiving alcohol, you know, heavy alcohol users, then I think you should prepare them with thiamine. I really think you should. IV corticoids if you have an allergic reaction especially. And anti-nausea. Well, anti-nausea, there's dihydronate and well, you know those names, right? I've taught, you know, people advise different things. You know, Anwar, you know, tells me one thing, Claire tells me something else. I think they're both right, just different contexts, you know. To be honest, and the people I've seen that are really struggling with vomiting, especially if their main symptom of withdrawal is vomiting, then when they start their withdrawals and people, you know, they try to give Ibogaine when mild withdrawals are starting, if their main symptom is vomiting, then you screwed up your timing of treatment, because they'll just start withdrawing, they'll vomit. If they're taking oral short-acting opiates, then what can you do? They're just vomiting, they'll go back to smoking heroin. It's not viable. So I think you should be aware of their vital signs, obviously, and if they're, for example, if you have somebody taking central-acting antihypertensives, then maybe you can give peripheral acting, like, you know, you can give peripheral acting antihypertensives, and maybe those antihistaminic anti-vomiting medication. It might be helpful because they help control the hypertension, and it's a 2-on-1. But if they have low blood pressure, maybe you should be thinking about something else. And some anti-nausea are QT prolonging, so I think you should be aware of the pros and cons of each medication. Try to do the best with what you have. Also, you know, you have natural solutions like ginger capsule, ginger extract. They're great. That's what I've seen. That's mostly used with clients, unless they're really, you know, hardcore pukers. And I think CBD oil, a good CBD oil, might go lengths to helping with nausea. Really, really seriously, might be a great side alternative. Yeah.
Consideration that when you get vomiting just before you start Ibogaine treatment,
yeah,
it's very common to be ulcers.
Oh yeah, omeprazole. Yeah.
Omeprazole.
So Anwar talked with me about omeprazole, which I think is okay. I'm not sure. I don't want to be saying anything incorrect here, but I was like, oh, QT, whatever. I agree with you. Ulcers are important. Yeah. So if you find it's helpful, you know, just give an antiproton pump inhibitor, and you know, omeprazole fits the bill pretty well, or as omeprazole, whatever. So Ibogaine sourcing, this is kind of controversial. You know, I have friends here, so I don't want to hurt anybody's feelings. But in my opinion, with complicated patients, especially, you know, poly users, comorbidities, COPD, unless it's heart problems, where I really don't recommend you treating them with Ibogaine. Really don't. I think we should strive, and I know it's hard, you know, We've seen Cisco's story yesterday. I know it's hard, but I think we should strive as a community, and there are great providers here and great people who are sourcing Ibogaine. I think we should strive as much as possible. It doesn't matter what country, we really need, if we're serious about Ibogaine long-term, GMP Ibogaine. At least for some clients. I'm not saying, I've seen most people use, HCl, which I haven't. I've seen mostly ETA and PTA, and those have been fine. But if we are dealing, and from the studies I've seen, HCl is great with heavy opioid users long-term, because it helps detoxing, it's more specific, and maybe ETA it's better for the whole experience and transformational stuff. But if you're treating a heavy, a 30-year-long heavy opioid user, then why not just detox for the first treatment and then maybe think about having 6 months later, a more psycho-spiritual focused session. Maybe that's safer. So the thing about sourcing is, and that's my question, and you can share your thoughts even on this slide. How can we know how to preserve it better? How to storage it? The potency loss over time, that's a big issue in my opinion. Even though Ibogaine seems really stable in dry and cool places and really closed, in a closed container. How can I know for sure the potency? How long will it remain that amount of potency? Because then I'm giving something I really don't understand how to use. There's no expiry date, so I think that's something. And even if you're dealing with TA or PTA, maybe have some way of measuring the percentage of Ibogaine that we're dealing with. At least that would be something to help the providers. So yeah, and some criticism, I don't know if this is accurate, but I saw in an article there's no formulation or stability studies. If that's the case, maybe we should strive for that on the next decade, and that's my view. Yeah, so this is kind of a call for all the Ibogaine providers and the community as a whole. I think sharing information, even if it's like in a more anonymous kind of way, I think that's really something that's really important. If we don't share information, how are we going to improve the services we provide? How are we going to share the information? Our insights. Oh, maybe we can give this, to take off the Ibogaine load. Maybe we could do X, Y, and Z to deal with preventing adverse events. As much as possible. Kind of creating a core way of sharing online. I know that's possible. There's plenty of platforms to do that. Just sharing insights and have those insights rated with likes, dislikes. I don't really care. Some way to share really useful information. We need a central hub of information sharing, so we can build this, because this is outside of the medical community. So how else are we going to do this if we don't create a community hub, at least online? I know it's hard to, go, Mexico and then Portugal and then go everywhere just to learn something new. As providers, we have our own lives, and we can't be available all the time to travel everywhere. But internet has allowed us to, do this pretty much effortlessly. So I really hope that I can give some strength to this idea. I'm behind with somebody like Jeremy. He volunteered right now, and we can start building something online, and I think that's pretty doable. So that's my view. Yeah. So ACLS, Jamie talked about it, and I'm very grateful to have had ACLS intensive course with her, specific for Ibogaine. I did ACLS before working with Ibogaine. Thank God I did that, because I think it's the best money investment somebody has ever made for me. It was really intense. I didn't have much time to study. I just had like 6-7 days. And I thought, oh my God, this is really a lot of information. Even though I worked in ER, but I didn't work with intensive care, so it's really something specific, In ER, sometimes you receive, dehydrated people, stroke. It's different. ACLS is really specific. The exam, the exam from a pragmatic standpoint. I did American Heart Associated supported ACLS course. You know, your algorithm must be spot on. You can't have serious mistakes unless, you know, otherwise you fail the course. And I think that's pretty fair. And it's some knowledge. It's like every 2 years. I don't say you should do a course, but I think you should revise all the information. And if you're working with Ibogaine, at least have the algorithms next to you when you're working. I think that's really something. And yeah, the charts and yeah. So online, those websites, maybe AHA has all those charts algorithms online. But besides doing the course, one thing is to learn how to do it in a dummy, and the other one is, you know, doing it live, and that's worse, much worse for sure. And I think the more fluid you have it, you know, even training with your team, at least one person, and the other people, if they don't have the course, they should know what to do, and the team leader should tell them, you know, you're doing IV, you're doing, you know, breathing, you're doing, you know, CPR, and at least they should know that, because that's really essential when time comes. And if one person knows ACLS, at least they know the algorithms and what to do. And I think that's really takes away a lot of the pressure at the moment of need. So the stuff, yeah, the stuff. This I think it's a really important kind of not ignored, but underspoken subject within the Ibogaine community. The stuff. From many people I've seen, you know, they work with Ibogaine and then they get trained. Even some lay providers, not non-medical providers. You know, oh, I work with Ibogaine and then I'm really tired. I'm going 90 days retreat, just Vipassana meditation, and then next year I'll come back working. So it really feels that it drains you. From my own personal experience being in the room, well, it's really draining. But that's for me. I'm too open and sensitive to whatever energies, and I don't know how to protect myself. From what I've experienced, at least centering myself within my own body and my own, you know, energy, whatever, it has helped me to remain focused and not get sucked into the universe of somebody who's experiencing Ibogaine. I really feel that can be really strong. It depends on the person that's taking Ibogaine, but some people, they really create, you know, a universe of their own when they're taking Ibogaine, and that becomes like a movie, and you get drawn into it, and sometimes it feels like an exorcism, and you're living like those 80s movies. So it can be really overwhelming. If you don't protect yourself, if you don't rest, if you don't have people you trust within your staff, how can you do this properly? You know, how can you pay attention to somebody's vital signs 3 days in a row? It's just not feasible. You'll get drained, and you'll make mistakes because you're tired. And I think this should be really seriously addressed if you're trying to do this properly. You know, whatever, just have people do shorter shifts. And I think that's a way to keep people fresh and paying attention. And yeah, so as well, the staff dealing with the clients, not even during the Ibogaine session, but before and after, you know. The staff dealing with the patients, it's also tiring, you know. Some people are really desperate, so they do desperate things. And they get, you know, really they put you on your toes, and they really push you to your limits. And sometimes, you know, you might really feel really frustrated. If you don't express that, then you destroy yourself from within. So I think you should really take care of yourself. Mindfulness-based practices, breath work is great, breath work is amazing, holotropic breath work. So whatever you need to make yourself feel better, take care of yourself, take care of this. So yeah, communication within the staff. I think that's important as well. Sometimes non-clear communication might lead to mistakes because somebody understood, you know, oh, you give him one pill of 400 and he understood the pill, or give him one pill of 200 and he understood the pill had like 100, so he gives 2 pills. So, you know, those kinds of mistakes. What to do, what to be alert about if you're dealing with people who are not as aware of what's important to pay attention in somebody going through an Ibogaine session. You need to be really clear, really specific about what's important. Sometimes they're being monitored, they have the electrodes, and they're just moving around, and the electrodes, the monitor gets all messed up because they move, not because of electrical activity. And people who don't understand this, they'll freak out. Oh my God, what's going on? You know, you understand, right? They get really they get really freaked out, and the patient's really, I'm okay, I'm okay. Oh, but the monitor, are you okay? Yes, I'm okay, leave me alone. So we need to understand what's important. In my opinion, the monitor should be second to the person's consciousness. Just check if they're feeling okay. You know, if they're speaking with you, then obviously they're probably better than you think they are. So from what I've seen, if somebody's electrical activity is honestly going worse, the person doesn't feel great at all. I've never seen somebody with seriously altered electrical activity saying, oh, I feel great, I'm in the clouds. I don't believe that. So I think there's some correlation. Always see how they feel and how they're breathing. If you're a non-medical trained or you don't understand electrical activities, just pay attention to the breathing and their overall consciousness. I think that's more important than looking at the electrical activity. Because otherwise you'll create, a lot of stress and panic. Oh my God, what's this? Because you don't understand what's going on and what might be a serious thing in the monitor or not. So I think it's unavoidable. You can avoid feeling anxious. Just look at somebody's overall state and try and be intuitive about that. Yeah, so decision making. Yeah, I'm not really imperialistic, so I think we should share information all the time with whoever works with us and other providers. And the decision making should be clear, but it doesn't need to be hierarchical. It helps to be hierarchical in some situations if you're working with people who haven't as much breadth and depth of understanding about Ibogaine. But at least open communication, so everybody in the staff feels comfortable sharing information with you, and they don't think, oh my God, this guy is a big shot doctor, I'm not going to say a word because he's, I don't know anything about it. Maybe the person has great input to give, so maybe we should listen to everyone and just do whatever feels best with all the information we have available. Yeah, so regarding the patient, when they do the application, those, like Jamie said, many people wanted to do covert detoxes, for sure. It's almost for sure. And if they weren't as obvious, like, opioid users, I would say people just, if they figured that they could do Ibogaine the same day they arrived at the clinic, I think most of them, if they knew that beforehand, most of them would be able to try and hide, obviously, as much as possible, their addictions and just say, oh, I'm just going for psychospiritual, it's just like ayahuasca. I'm not going to tell them I have 10 issues, they'll just, accept me, hopefully. So that's what I've seen happen. Somebody with serious arrhythmias, past history, basically, omitted that out of forgetfulness or not, I don't know for sure. But then that can really bring serious situations. And it's your responsibility as a provider to be as meticulous, thorough, and as it's spy stuff. We have to know information. We have to extract. DiCaprio Inception. It's kind of that. So if you're not doing the application interview face to face, which I think it's the best way to know somebody, at least an online interview. If you feel somebody is trying to omit information, an online interview, you see the gestural language. Gestural language? Yeah, gestural language. You'll see how they're trying to dodge some questions, dodge some information. If you're quite spot on with your intuition, you'll see when they're trying to hide stuff. And so try to make them comfortable, feel comfortable, so they feel that they will be accepted in the program regardless of the information they share, and then they share everything with you, and then you feel like it's safer. Yeah, and that's it. If you can speak with friends and family, then great. More information, great. So try to have the personal and as well medical, personal and family medical history. Some people have premature heart family history, so disease, so you should pay attention to that. And obviously all the substance use profile, all substances, drugs, illicits, prescribed drugs, weird foods, like that citrus fruit, I don't know the name, in grapefruit, yeah. So at-risk behavior as well, IVs, no IVs, and then this is really not really spoken, or at least not in the past, but some supplements, some vitamins, some plant substances, they might be really risky. And kava kava, from what I've seen, I don't want to point any fingers, sorry kava kava, but kava kava, kratom, some other substances, all their interactions with their ongoing prescribed medication, the drugs they are taking, you know, and then their history. I don't want to say any wrong things, but I think kava kava, high doses of kava kava, if you're withdrawing, you can have seizure-like activity. So if that's the case, and I'm almost sure it is, then you should be really paying attention to what kind of plants they're taking, and really be serious about telling them this is okay, this is not okay. If they're taking vitamin C, well, then it's fine. But if they're taking weird plants, really investigate. Some stuff is not really well studied, and if you go to WebMD or pharmacological websites, you really won't find tons of information, which is unfortunate, but they're not medically studied extensively. So I think you should play safe and try and have them stop those weird plants with enough time to let them be metabolized and go through the possible withdrawal symptoms. If that's the case with kava kava, maybe he needs medical guidance wherever he lives to a slow taper, or don't accept him on the program. CYP2D6, I put it here not because of the lab test screening, but because of the enzyme interactions. If you're taking pharmaceuticals, then you should be paying attention to this enzyme and see whatever pharmaceuticals the person is taking. Obviously, they'll compete with Ibogaine for the metabolization, so you should be really paying attention to that. GABA, pay attention to whatever substance, prescribable or illegal, but they're almost always prescribed. And also supplements, because GABA supplements, not L-theanine, which works on the glutamine pathway, but GABA pathway substances, you should pay attention. It doesn't matter if they're natural, if they're lavender or just a molecule. They will, if they're taking high doses, they'll withdraw anyways, and they'll have a higher likelihood of having seizure episodes. So pay attention to that. And those three main things. And QT, always see if their medication affects QT, please pay attention. Methadone is a big no-no, obviously. So have them change to, what? 5 minutes? Yes, sir. Okay, fair enough. Okay, so let's go. So the screening, this is what's recommended on the Gita. Please read Gita if you're providing. It's really, really great. Yeah, these are the recommended screening tests, and these are just, please, IV, try and test at least for Hep C and HIV. I think it's really important. Obviously, the liver enzymes. Quantitative drug tests, if you're able, that's especially great for benzos, I would say. And obviously this is more discussable, but Roman also already talked 10 to 15, at least Caucasians, but somewhere else on the planet might be a higher percentage of people with hard metabolization within this enzyme. Yeah, so just see the Gita exclusion-inclusion criteria, and I would say if you're doing, exceptions to the criteria on Gita, don't do it with cardiac risk factors. It's just well, I'm really serious about this. If you're trying to just do a Holter, a stress echocardiogram, stress EKG, stress echo, try to push as much as possible the exams to protect yourself. But sometimes the Ibogaine is a metabolic stressor and not a physical one, so it works differently. So somebody, I'm a great sportsman, I run every day 10 miles. Maybe they can't deal with metabolic stresses, we don't know. I think this is a really understudied area of the Ibogaine science, so go ahead. Yeah, so intake, be really serious about receiving people in your facility. It's so easy to smuggle stuff. It's really, really easy. Don't accept any liquids. This is my water rinser, water mouthwash, whatever. They can lace it with liquid, stimulants, whatever. You will never trace it. It's impossible. So if you want to do this 100% safe, just, prison style, naked, just give some cotton garments and that's it. Yeah, do the house and sows when they arrive. It's a great tool just to add up to, to protect yourself and to add up to your medical data. And yeah, be serious about doing at least urine drug test when they arrive at your facility and the day of treatment. Because if they're staying for pre-care, they might find a way to smuggle stuff, and then you did the urine test at arrival, and then they took stuff while they were there, and then you screwed. No, just protect yourself. Electrolytes, EKG, always check the electrolytes at least the day before, at least, at minimum. Yeah, so preparation, there are several things we can do to improve somebody's physiological preparation towards receiving an Ibogaine treatment. If you're doing benzo tapers, for example, just read the Ashton manual. It's really invaluable information. It's really great. Prepare the electrolytes, oral dieting, like, papaya, bananas, avocados, whatever oral electrolytes you want to replenish, just pump them up with all good juices. And I think that's great. Probiotics are great. Many people don't talk about it. They're really great. Most people have destroyed their gut flora. So yeah, and it improves your own health. You have more bacteria in your body than you have your own cells. So I think you should pay attention to that. If somebody is willing to study orthomolecular medicine, then you have much more tools to work with and preparing somebody's body to receiving Ibogaine. Supplements as well, and please no harsh detoxes, because you're just stressing the metabolic, the metabolism of the body, the liver, the heart, etc. Yeah, so basically this slide is really interesting, 3 words to play with, but basically what works in studies, what works in science, in basic science, what works in clinical studies, and what works in your experience as a provider. Please do what works, what you've seen it works. It's not because a mouse took, this kind of protocol, it's feasible for humans. Just try and see what works and be pragmatic. Evidence-based medicine, although I like science a lot, evidence-based medicine is the first. It's what works. So yeah. So dosing. So flood, cumulative. Talk with providers. I would advise against doing flood with really, really fragile people. Just try and detox them slowly, and see how their body reacts. And don't give huge doses if you're not sure that they will that their bodies are able to handle it. Please, safety #1 priority always. And just the way I've seen people study. Wow, 3 minutes have passed. Great. Decision making. So I think people should be less strict about following, a protocol like a recipe. Oh my God, I'll do the bimbi recipe and then it's perfect, like 40 minutes, 180 degrees. Well, I don't think it works that well with Ibogaine. There's too many unknown factors, so I think we should always see the vital signs, someone's consciousness, and then you try to assess what to do next. I think that's the best thing to do. And if you're great with a monitor, then you can see the warning signs of please stop Ibogaine right now and do something else to make them comfortable. If that's necessary, just don't give more Ibogaine today. Maybe we resume the treatment some days afterwards. So this is like showing if you give the same amount but over 3 days or in one go, and if Ibogaine is toxic for the heart in this amount of blood concentration, then if you're doing it spread over 3 days, then you don't ever cross that threshold. We don't know those thresholds for sure. This hasn't been properly studied. But there's also the problem of the psycho-spiritual threshold. How much do you need in your blood until you have a psycho-spiritual experience? It's really hard to know that. This is really, case by case. So try and use your intuition. If you feel their overall state is not fine, be really attentive and not, play your odds and just giving them, let's give him a teaspoon of, 2 grams of TA or whatever. Just play it safe. Yeah, listen to their feedback. They complain all the time. Just ignore the complaints and see what's medical and what's relevant, Yeah, well, when I'm under plant influence, I'm really needy, so I know the other side of the coin. It's really annoying to deal with somebody like me on those situations. So I think you should always listen to their feedback, but don't talk too much. Just worsens the experience. If they want to share, if it's irrelevant, just don't answer, but try to get some medical relevant information. Yeah, so taking the therapeutic load off of Ibogaine, you know, if some people disagree, but if you feel they have had too much Ibogaine, just try and use other alternative pharmaceuticals to make them as comfortable as possible. If they want, you know, to resume treatments sometime later, next 2 days afterwards, but play it safe. You know, it's better to suffer than, you know, something worse happens. And safety number one priority, I would say, and it's not here. Healing priority number two, and comfort priority number three. If they're suffering for 3 days and then they get, you know, months or years of no relapse, then why not suffer for some days? As long as they're fine and their bodies don't get permanent injuries, I think that's worth it. That's my opinion. Yeah, vigilance, tight vigilance. Always watch if somebody is leading the team, see if their judgment says, you know, this is really serious, this is really dangerous, you should have tight vigilance. In my opinion, somebody should always be watching the patient in the same room and at least making sure they're breathing, and not breathing like with their belly to the mattress, because otherwise it's not proper breathing. If they're in risk of vomiting, side laying down, and if they're not, just belly up, and I think that's the best way of putting less pressure in the abdomen. It allows for better breaths, better diaphragm breaths. So yeah, I've seen people with already struggling hearts with the premature ventricular contractions moving, getting agitated, or going to the bathroom, and that's when the things went south for them. So you know, if you can convince them of using a diaper, well, less stress for you, less stress for them, less, you know, orthostatic body balance. You know, they're lying down and then they have to get up and the blood pressure gets messed up and they have to, you know, use their autonomous nervous system to compensate the blood pressure. It's really hard. I've seen purging really help with the electrical activity. It seems weird, but it works. So I would say purging through any ways, you know, upwards, downwards, whatever way, you know, yeah? Okay, just... We have go to 5 now. So pay attention to this. If this happens, just call the emergency. Don't play your odds. Yeah, go. Whatever. Yeah, study Gita. Great. Well, so the last part, basically harm reduction after discharge. Just please confiscate all their dangerous pharmaceuticals and, you know, oral morphine sulfate, whatever. You never know, but at least don't risk yourself. Let them suffer their way home if they're not fully out of withdrawal symptoms, but don't allow them to take, you know, prescription opioids immediately after they leave your facility. It's too dangerous. Yeah, thanks, Agnes. So, yeah, when they leave your facility, you should really study the slides afterwards. No, I'm kidding. You should really try and protect the patient. In my opinion, I try to protect the patient first, and then me secondly, and try to do what's best for them. If you're going to give, by whatever reason, boosters home, they need to be someone responsible. If you're weak with them, then you'll be able to assess if they're responsible enough or not. So, yeah, another plant treatments, well, some people talk about Cambo and ayahuasca and the time that you should wait before you do them, or before even you do another Ibogaine treatment. I think you should be consulting other providers here and get the feel of what's viable, what's not. So, yeah, that's it.
Okay, thanks.
Yeah, so for those who want to study more stuff, basically, you know, Gita's website, Ibogaine Alliance, I think it's a go.
All the presentations we will make available. So next week we'll send a link to the Facebook group for the conference, and you'll be able to download all the presentations. So a couple of quick questions before we go on to the next presentation. Anybody? Roman.
Yeah, IV corticoids. Yeah. I think it's, well, if you have an allergic reaction, not to Ibogaine, I don't think that's really likely to Ibogaine. But whatever other, I'm saying, I'm avoiding adverse events in an Ibogaine treatment clinic, but they can have peanut allergy. I don't know, right? So peanut allergy, then FDA comes. Oh my God, it's Ibogaine. You know, just let's not risk it. I would say, and if maybe having an EpiPen might not be a bad thing to ponder. Yeah.
Any other questions? Nope. Anwar.
Yeah, the part you spoke about sharing.
Yeah.
I think it's a pretty good idea, but when it comes to dosage,
No, it's different.
it's very difficult to get an idea on how we can share, because people got different protocols, different ways to dose, and that might suit them fine because they've been working with it for some time. They didn't study that protocol or that dosage protocol from books or anything. It's something that they found out as they were treating people.
Yeah.
So maybe that protocol might work well for that person, but might not work well for somebody else.
Yeah.
So I think we have to be very careful when it comes to the dosing aspect. When it comes.
Well,
to
sure,
sharing.
but that's my, it's each provider's responsibility to be wise about what they do. I'm not gonna copy your protocol and then mess it up because I'm inexperienced and novice, right, Anwar? I think we should just share what we do, and that's it. Just share, and somebody else will just study all the options and see whatever fits for them. I'm not saying copying somebody else and just,
No, there's no problem in copying.
Yeah.
The problem comes is that when you get too much of information,
Okay.
which are different to the others.
Okay.
And that now when you are currently doing the treatment,
Yeah.
now you say, okay, maybe I should switch to that protocol because I think of this. And
Agreed. And regarding different kinds of protocols and approaches, obviously the protocol depends on your screening and your preparation. It's not an isolated protocol, right? You prepare the patient firsthand. But I think I think sharing is important because, creating a single kind of all-fitting purpose protocol is kind of hard because, you have your own way of doing things. Claire has another one. I might have another one. It's really hard, and then we have to agree about everything, and it's hard, to not create some confusion. And although I agree, sometimes it might create some harm for some, new providers. Oh, there's 10 protocols. I'll do one day, and then this doesn't work. I'll do somebody else's protocol. And then they'll mess up stuff and they'll make mistakes because they're mixing up everything. And I think that might be a huge risk. So I think even if you don't share all the information, you're making it less risky. If you're sharing all the information, you might benefit. It's kind of a balance. We have to see what to do about it. But I think we should always share. It's just harm reduction. Otherwise, it's just like forbidding, drugs or whatever. Oh, we forbid everything. There's less harm. Well, maybe not. I think the more transparency we have and the more awareness we bring to people, maybe the less mistakes we have because people will be weighing the pros and cons better. They have the tools in their hands. So that's it.
I think Fred is an excellent walking, breathing example of sharing. It's great how he's absorbed information from different providers and the wisdom from different practitioners. And it's excellent that we have a young medical doctor who's interested in Ibogaine and bringing the kind of medical rigors to provision. So thank you, Fred. Last presentation talk before lunch will be Anwar Jiwa on a completely different subject or sort of related to adverse events.